and Immunology. And, this is not the 9th Charles W. Parker, it is the 10th. I have that wrong. I didn't edit that part of it. So Charles Parker was really laid the foundation of allergy and immunology research here at Washington University, and he left big shoes to fill. And this lectureship was donated. There was a donation by his family in his honor to do this, and they're usually with us, but they've moved out of town, so they're not able to be here today, but we hope to have them back in future years. So Dr. Parker really did a lot of seminal work in our area. In drug allergy, he defined the immunochemistry of penicillin allergy. He was a biochemist, and developed the first and only valid drug allergy skin test and desensitization procedure. And they were published in 1962 to 1964 and are the ones we still use today. He also helped define the immunology of hapten drug IgE interactions, the use of anti-tumor conjugates for cancer immunotherapy, fluorescence quenching to measure antigen-antibody interactions, which means more to those of us in immunology than probably the rest of you, but expanded the role of the radioimmunoassay in medicine, demonstrated that slow-reacting substance of anaphylaxis was a metabolite of arachidonic acid, and showed that the side chain on leukotriene C4 was a glutathione. He showed that cells that were deficient in glutathione could not make leukotrienes. And all of these studies led to greater understanding of mast cell mediators and allergic responses. And I actually learned a lot about the leukotrienes from the man who's going to speak today from Stokes Peebles at Vanderbilt. So, and may not be my edited, some of my edits got left off. Okay, so Stokes is an old friend of mine. We met at Vanderbilt probably in the late 90s when he was a fellow and junior faculty, and I was a resident. He started his training at Davidson College in North Carolina as a pre-med, and then went to Vanderbilt for his MD, and he has stayed there a lot. He did residency, he did chief residency at the VA, then he did his fellowship in clinical, and I can speak in a minute, allergy and clinical immunology at Johns Hopkins, and then a second fellowship in pulmonary and critical care medicine back again at Vanderbilt, where he then joined the faculty. So he joined in 1998, and I'll skip some things and say he rose to become a professor of medicine as well as pathology, microbiology, and immunology. He has the Elizabeth and John Murray Chair in Medicine. He's been section chief of Allergy and Immunology for over a decade. He has been the director of the Allergy and Immunology Fellowship Training Program for almost as long as I've known him. He is now Associate Chief of Staff, Research and Development at the Tennessee Valley Healthcare System and the Department of Veterans Affairs. So he's our ACOS and is making great headway there. So I wanted to say a few more things. So Dr. Peebles' CV is 77 pages long. I was there for just about every line of those, and I can tell you that he is an incredibly hardworking person. He's always working. In addition to being super, super smart, he'd be up at the gym at 5:30 in the morning playing basketball, and then go to work, and then pick his kids up, take them to their sports games or practice, which he also sometimes coached. And then at work, he was a coach as well. So he has trained or mentored dozens of fellows, postdocs, and graduate students, more than 10 in his own lab. All but one of the postdocs and students who trained in his lab are now in academic medicine. Many of them are grant-funded with their own labs. There's one maverick who's a founder and CEO of a vaccine company. As the Allergy Immunology Fellowship Director, he taught basic immunology, which, as you probably know, is a foundational component of our specialty. It makes up a quarter of the questions on our board exam, and I can assure you that with Stokes at the helm, we learned that immunology. He would use the Socratic method at 7 in the morning. We would have prepared 4 hours the night before, and he would go around and ask us questions one at a time. going over the alphabet soup that designates the cellular and molecular functions of immunology. So that was a really great learning experience for me, and it deepened my knowledge and joy in immunology. Now, we are not always encouraged to use Socratic method these days. I still think it's a great method. But Stokes is really a very kind person. He's not mean at all. He is unusually kind for people who become highly accomplished scientists. Despite his hardworking ethics and his high standards, he really cares about his people and his colleagues. He's really well known for that at Vanderbilt. Everybody knows that he cares about them. He will make time for you anytime, and when you go sit in his office, he puts everything aside and gives you his full attention. He also, you may have noticed, for those of you who talked to him last night at dinner, that he turns the conversation toward the person that he's talking to and away from himself. He's just extremely humble about himself and his own work. When I first met him, Stokes was just beginning his scientific career. He had a KO8 to study airway reactivity induced by respiratory syncytial virus and its relationship to allergy, and he built a lot of really great work on that. A lot of the work Stokes does tends to draw in different related fields and look cellularly at how those factors interact with each other. His mentor, Barney Graham, left to go to the NIH, leaving Stokes on his own. They talked by phone weekly, but there wasn't anyone else at Vanderbilt really working directly in his area, and he did not let that deter him. He was a highly driven, highly knowledgeable scientist, and his early work led to over a dozen major NIH or equivalent grants, over 200 papers delineating various cellular and molecular contributors to the pathophysiology of asthma. He also has contributed greatly to the field by serving in multiple leadership roles at the American Academy of Asthma, Allergy, and Immunology, and also at the American Board of Allergy and Immunology. I think he had some of those board questions left over from our training. Stokes' scientific contributions in the field of asthma include the study of prostaglandin regulation of allergic and RSV-induced lung inflammation, as well as the relationship between IL-17 and airway disease in the context of allergic and viral inflammation. And he's also studied the role of cyclooxygenase in adaptive immune response and tolerance. So some of his more recent work concerns a link between asthma and obesity, which he's going to tell us about today. So let's make him feel welcome.
Well, that almost made me want to cry. Peggy, that was really nice. Thank you very much. And it was, I do remember the day I met Peggy, actually. She was a med-peds resident in the ICU, and I was a pulmonary fellow. And I thought, man, this woman has it all going on, and I was right. And it's a great opportunity to be here, so thank you very much for inviting me. So one thing I'd like to start off with is talk just a little bit about Dr. Parker. Peggy talked about his scientific accomplishments. And last night, I found out more about him personally from about the best judge of character I know, Dr. Philip Kornblatt. And Phil said that Dr. Parker was a prince of a guy, that everybody loved him, and he was such a great influence on all of those with whom he came into contact. So it's a great honor to be here to celebrate the legacy of Dr. Parker. So what I'd like to do today is to talk to you about two different things in general. One, I'm going to talk to you about obesity and its relationship to asthma. We're going to talk about some epidemiology. We're going to talk about the mechanisms of how obesity interacts with asthma. And then we're going to talk about inflammation. And then I'm going to pivot about halfway through and talk about work that we've been doing over the last 7 or 8 years now, some preclinical studies which show that a class of drugs which are FDA approved for the treatment of obesity and asthma, these are the GLP-1 receptor agonists, actually have very potent anti-inflammatory effects in the lung. So this is a completely different way of thinking about these drugs, and I think that they could possibly be used in asthma, and we're going to find out because we have a clinical trial that's funded by NIAID looking at the role and the effectiveness of GLP-1 receptor agonists in people who are obese and have asthma. So there is some clinical relevance to my talk today. So what I'd like to do to start off with is just talk a little bit about epidemiology. And this is the latest data that we have looking at asthma and obesity. This is from 2010. Unfortunately, it's 13 years old, but it is the most recent data we have from the CDC. And if you look here on the y-axis, you see the percentage of people who have asthma. You see in the dark blue, normal weight people, in the gray, overweight, and that's defined by a BMI of 25 to 30. And then obese people who are over a BMI of over 30. If you looked at all Americans that are adults, you'll see that about 7% of normal weight people have asthma. A little bit more of overweight people have asthma, but there's a significant increase in the people who are obese. In men, there really doesn't seem to be much effect, but the effect is much more pronounced in women. You'll see that there's almost a doubling of the percentage of people who have asthma in women who are obese compared to those who are lean. And so that's a really important thing, because if you take a look at the whole U.S. population, an increase in about 7%, you know, that's several 100,000 or millions of people. So why is this taking place, and what is the relationship here? Well, first, what I'm going to do is tell you that there is a dose-response relationship between obesity and asthma, and particularly in women. So you see that here a little bit, but even when you stratify this out more finely, looking at BMIs from 25 to 30, 30 to 35, 35 to 40, it's even more pronounced, the dose-response relationship. Now, one of the questions you have is, well, is it obesity that leads to asthma, or is it asthma that leads to obesity? If people have asthma and they're not exercising very much, are they more likely to become obese? And that's a relationship that actually we're also looking at Vanderbilt. There's also an increased incidence of asthma severity. If you look at all of people who have severe asthma, 60% of those people are obese. So these people not only have asthma, but it's more severe. They have a 4 to 6-fold increased risk of hospitalization, and they also have more exacerbations. Not only when they have exacerbations, but even when they're not having significant exacerbations, they have more symptoms. So this affects their quality of life very substantially. Not only that, but they don't respond to the medications very well. So if you look at their response to beta agonists, which is the cornerstone of rescue inhaler or rescue treatment, or also inhaled corticosteroids, they don't respond very well. Now, this is going to be even more pronounced as we go along in the future, because at least in Nashville, here we see the star right there on Nashville, is projected to be 60% of people will have obesity in 7 years. So right now, we're somewhere around 40%. So and going to the mall, I can attest to the fact that the younger folks are also obese, and so there's a very good chance that we will have an even greater incidence of obesity, and that's going to markedly impact our asthma as we go along. So now what I'd like to do is talk a little bit about the mechanisms by which obesity might affect asthma. And first, we're going to start with the low-hanging fruit. We're going to look at the physiology. So this is a small airway on end. So in the blue here, this is where the air passes through. Asthma is not a disease of the large airway. It's not a disease of the trachea or the large mainstem bronchi. It's a disease, and it's not a disease of the alveoli either, such as COPD would have, where you have destruction of the alveolar capillary bed. Asthma is more of a disease of the small airway, and so we're talking about the terminal bronchiole and just proximal to that. So around the small airway, in green here, I've designated the epithelial cells that line the small airway, and then around the epithelial cells, or supporting the epithelial cells, we have the lamina propria, and we also have structural cells, collagen and other structural cells that form the small airway. Now, the small airway is actually kept open. You're not seeing any cartilage here. So the small airway is kept open by alveolar attachments. So the alveolar attachments, the things that form the wall of the alveoli, actually keep the airway open. So the alveolar attachments consist of epithelial cells, also endothelial cells in the capillaries in the air in the alveoli, and also fibrous tissue as well. So when you take a deep breath in, and everybody takes a deep breath in, your lungs are going to expand, and as a result of that, in a second I'll show you, here we see the alveolar attachments. When you take a deep breath in, it pulls the alveoli open, and the small airways open, and that causes this tethering effect, causes the small airway to enlarge. And this is really important because this is going to allow for greater airflow. So if you look at the Hagen-Poiseuille equation, if you have a change in your airway, if you double the size of the airway, for instance, you're going to decrease resistance in that airway by 16-fold. So that's very, very important, because here we see the alveoli. These blue areas here are where the alveoli, where the air is and going through gas exchange. And these tethering effects on the fibrous tissue is going to pull the small airway open. Now, if you look at somebody who's obese, you're not going to see that as much because of the fact that they have a decrease in their functional residual capacity, because of the fact that they have adipose tissue on their chest, adipose tissue on their abdomen. They're not going to be able to take the same deep breath in that the rest of us are. And so that has major effects on the airway. First off, it's going to lead to increased resistance, because I told you if the airway's not enlarging with these tethering effects, you're going to have more resistance. Not only that, but when you run into a situation where you have an allergic response, for instance, let's say you're allergic to cat. You go into a room with a cat, the mast cells degranulate, they release leukotrienes, they release other bronchoconstrictors like prostaglandin D2 or histamine. If you're starting out with a smaller airway, the effect of those bronchoconstrictors is going to be much greater than someone who has a normal airway and who is already somewhat bronchodilated. So this is the low-hanging fruit, so to speak, because of the fact that there is a mechanistic reason that people who have obesity are going to have greater problems with bronchial responsiveness. Now, not only that, but it's also very interesting in the fact that people who have obesity, their adipose tissue not only is in the belly or on the chest wall, but it's also intercalated with the smooth muscle. So if you look at the airway of somebody who has asthma and obesity, and you look at their smooth muscle, they're going to be adipose cells intercalated in with the smooth muscle, and that's going to affect smooth muscle function. So this was a paper that was published just last year, and what they did was they looked at the adipose tissue in the body, and they looked at it through CT scans, where they looked at the lower paraspinous muscle density, and it turns out that the lower paraspinous muscle density also correlates with adiposity in the airway smooth muscle. So if you have a lower paraspinous muscle density, that means that you have more adipose tissue in the muscle. And it turns out that people who have asthma, and not only asthma, but also people more prominently so in people who have obesity and asthma, they have greater adipose tissue in their smooth muscle, and that's going to affect their ability of the smooth muscle to relax. So if you have a lower density of the paraspinous muscle on your CT scan, it relates to a lower FEV1. And FEV1 is the fraction of expired, or the forced expiratory volume in 1 second, the amount of air that you can blow out in 1 second, which is a measure of airway obstruction. And it's more pronounced in women, again, than men. And that may be part of the thing that we're seeing, as I showed you earlier, the greater degree of asthma and of asthma severity in women who are obese than in men. Now, not only is there an effect on smooth muscle, but there's an effect on metabolic derangements and also on inflammation in the body. So this is a really interesting study that was published by Michael Peters and his colleagues out at UCSF now about 7 years ago. And what they did was they looked at 3 different populations of people. They looked at people who were at UCSF who were healthy, who did not have asthma, nor were they obese. They looked in the middle here at the people who were at UCSF who had asthma, and they looked at the Severe Asthma Research Program. This is an NHLBI funded study. It's actually looking at people who trying to determine the mechanisms by which severe asthma occurs, and they also looked at plasma IL-6. So IL-6 is a marker of inflammation and also metabolic dysfunction in people. In healthy people, they had lower levels of IL-6, and then when you looked at the asthmatics, and these were not severe asthmatics in this middle, these were moderate to mild asthmatics, there was a significant increase in the IL-6 levels, so that about 20% of these people had what were considered to be elevated levels of IL-6. When they looked at the people who had severe asthma, there was an even greater proportion. So it shows that people who have severe asthma have greater metabolic dysfunction and greater systemic inflammation. Now, also in this study, they also looked at IL-6 in relationship to obesity and asthma. So first, what they did was they stratified the patients, whether they had a BMI of less than 30, or whether they had a BMI of greater than 30. And I'm not sure that, I apologize, I thought that the pointer was on here and it's not, so I'm sorry about that. Okay. Well, okay. So if they looked at the BMI of less than 30, what they found that only 8% of the people had IL-6 high levels. So that's shown in the lighter red bars here. And then the number of participants are shown on the y-axis. In those people who had a BMI of greater than 30, about 40% of these people had IL-6 levels that were high. Again, showing that people who were obese had metabolic dysfunction. Then what they did was they looked at the people who had asthma. And here they look at the average of the FEV1 against the forced expiratory volume in 1 second as a percent predicted. Those people who had lower BMIs, less than 30, they looked at those people who had low IL-6 levels, and their FEV1 was about 82%. When they looked at those people who had high IL-6 levels, there was a markedly significant decrease in their FEV1 to about 68%. So this is a huge difference in the pulmonary function of these patients. Then they looked at those people who were obese with a BMI of over 30, and in this group that had IL-6 low, they still had a significant decrease in their FEV1, which is not a great surprise given what I told you before about the ability of the chest wall to be affected, but also there was a decrease in the FEV1 in those people who were IL-6 high. So this is a very interesting study in which they showed that if you had higher BMI, you had more metabolic dysfunction, and also you had more systemic inflammation, and that was correlated, not necessarily causative, of decreases in the pulmonary function of those people who had obesity. Now, what do you need to do to prove an association? You have to do an intervention study looking at IL-6 antagonists and see whether that has an effect on asthma. And I believe the folks at UCSF are currently doing that study. This is another study actually looking at insulin resistance, again from Michael Peters and his group at UCSF, and they found that insulin resistance actually was also related to lung function trajectory. So they looked at the homeostatic model assessment of insulin resistance, which is HOMA-IR here, and that's a measure of resting pancreatic beta cell function. And to get this measurement, what they do is they take the baseline glucose in the serum, they multiply it by the baseline insulin level, and then they divide it by 405. I'm not sure how they came up with that, but in any case, what they came up with is if you have a HOMA-IR of less than 3, then those are people who do not have problems with insulin resistance. Those people who have a HOMA-IR of 3 to 5, that's moderate insulin resistance, and greater than 5 is people who have severe insulin resistance. And this is the breakdown of the subjects that they had in their study. There were about 25% who had severe insulin resistance and about 25% who had mild insulin resistance. Then what they did was they looked at the post-bronchodilator FEV1 as a percent predicted. So post-bronchodilator, that's when you bring somebody in the pulmonary function test lab, you give them albuterol, you wait 15 minutes, and then you measure their ability to bronchodilate. And what they found was that those people who had no insulin resistance had normal FEV1 over the 5-year period of the study. So that's very, very interesting. Then those people who had moderate insulin resistance, they had a significant fall in their FEV1 as a percent predicted over that 5-year period of time. So the slope is really great here, and this shows you that insulin resistance is strongly associated with decreasing pulmonary function. When they looked at the people who had severe insulin resistance, again, there was a significant decrease in their FEV1, not quite as severe as the people who had the mild insulin resistance, but they were already starting at a lower baseline, so they didn't have as much room to fall as those people who had mild disease. So this is, I think, a really interesting study that shows, or that seems to suggest that it's not just obesity, but also insulin resistance is associated with severity and asthma and the decline in function. Also in this study, what they did was they wanted to look and see whether patients who had insulin resistance, whether they had normal responses to the medications that we use in asthma. So what they did was they performed a maximal bronchodilator response test. So again, they came into the lab, they gave them albuterol, they measured their pulmonary function about 15 minutes later to see if they had a maximal response. And what they found was when they looked at the different HOMA-IR categories, less than 3 being normal insulin resistance, 3 to 5 moderate dysfunction, and greater than 5 being greater dysfunction, and they looked at the FEV1 as a percent change, they saw that those people who had greater insulin resistance had a decreased responsiveness to beta agonists. Again, so these people not only are they having lower pulmonary function, but they're not responding to the medications as well. They also looked at the systemic corticosteroid response test. Again, they gave a maximal dose of dexamethasone. And they looked to see whether these people had a responsiveness in their FEV1. And what they found was, if you compare the blue, which is the no insulin resistance problem, to those who had mild or severe disease, it was much greater. They had a much decreased responsiveness to systemic corticosteroids. So this shows you very clearly that the people who have problems with asthma and obesity and also in insulin resistance are not as responsive to the medications, which suggests that maybe we need some new types of medications to treat these people. Now, how does insulin resistance, how does that relate to pulmonary function? And I'm going to just briefly show you this diagram, which I think is really interesting. So here we see epithelial cells that I've drawn here. If there's a bronchoconstrictor stimulus, let's say there's some type of pollutant in the air or some type of irritant, or it might be leukotriene C4 or prostaglandin D2, these irritants, for instance, can activate sensory nerves, which then can activate the parasympathetic nervous system. So, for instance, if you're exposed to an irritant and you stimulate the sensory nerve, what you want your airway to do is to close down to protect you from further exposure to that stimulus. Now, that's great if you have normal lungs, but if you have asthma, that may not be a great thing. But in any case, the sensory nerves activate the preganglionic parasympathetic nerve, which activates the postganglionic parasympathetic nerve, and it causes the release of acetylcholine here. Now, acetylcholine can bind to the muscarinic M3 receptor on smooth muscle to cause bronchoconstriction. And this is what we try and reverse this effect when we treat people with ipratropium, for instance, or tiotropium, which is the muscarinic M3 receptor antagonist. However, acetylcholine can also act back on an M2 receptor on the postganglionic parasympathetic nerve. And when acetylcholine binds to this M2 receptor, it prevents the further release of acetylcholine. So this is actually a protective effect when acetylcholine binds to the M2 receptor. Well, it turns out that insulin actually prevents the activation of this M2 receptor, so now you have even greater acetylcholine release. So insulin not only has effects in the metabolic realm, but also effects on airways. A couple of other studies I'd like to share with you before we get into the research that we've done is this is a study that was published actually just about 3 years ago now. It was a genome-wide genetic correlation study trying to determine what genes were related to asthma and obesity. And so this is a paper that was published in the Journal of Allergy and Clinical Immunology, and they looked first at late onset asthma, and they defined late onset asthma as asthma occurring after 16 years of age. And what they found was when they looked at BMI, it was highly correlated with late onset asthma, so 10 to the minus 22nd. So this shows you that late onset asthma is clearly associated with obesity. They also looked at the BMI adjusted weight-hip ratio, and there was a little bit of a correlation, but not nearly as much as with type 2 diabetes or an increase in fasting glucose or an increase in fasting insulin. So again, suggesting that insulin resistance is certainly associated with the development of late onset asthma. When they looked at early onset asthma, and this is in children, which is almost all allergic in nature, which we would call type 2 high asthma or type 2 high inflammation, there was no association with obesity. When they looked at non-atopic asthma, again, this is non-type 2 asthma, and I'll go over that definition in just a few minutes. This is more neutrophilic in nature. There was a significant correlation of BMI with non-atopic asthma, suggesting that the inflammation in non-atopic asthma that's caused by obesity may be a significant player in the mechanism of how these people develop airway responsiveness. When they looked at atopic asthma, these were people who were adults. There was a little bit of correlation with obesity, but not nearly as significant as what we saw with the non-atopic asthma. So again, suggesting that the inflammation in people who have obesity and asthma is completely different than people who have purely atopic asthma. So how does this happen? Well, this is a study that was published now about 2 years ago in the Journal of Allergy and Clinical Immunology. And what they wanted to do was determine the mechanism by which they saw an increase in the neutrophilic asthma that occurs. And they specifically targeted the NLRP3 inflammasome. Now, we have the NLRP system in our body to help protect us to recognize foreign pathogens, either bacteria or viral infections, and these can be activated by pathogen-associated molecular patterns or damage-associated molecular patterns, or also homeostatic mechanisms of processes within the cell. So just to walk you through how the inflammasome is activated in the cell and specifically related to obesity. So here we see the damage-associated molecular patterns or DAMPs, or the pathogen-associated molecular patterns or the HAMPs. They can activate when the pathogen recognition receptors are activated by these PAMPs, or DAMPs, or HAMPs. That what happens is there's an increase in transcription of the NLRP3 gene. And not only that, but also an increase in pro-IL-1 beta. And pro-IL-1 beta is a very important, or IL-1 beta is a very important cytokine in driving neutrophilic responses. So you have an increase in the production of NLRP3, and there's a second step where there's activation, again, by these DAMPs, PAMPs, and HAMPs, where they bind to the receptor, they cause an increase in reactive oxidant species production, and then this activates the NLRP system. The activation of the NLRP system causes an enzyme to cleave pro-caspase into caspase-1. Caspase-1 is an enzyme that cleaves pro-IL-1 beta to the active form of IL-1 beta. And so this system, this increase in the NLRP is markedly increased in people who have obesity, and we know that because we can measure those products in the sputum, and that leads to an increase in neutrophils in the lung, also increase in neutrophil extracellular traps, which is the DNA that's extruded from the neutrophil. It's toxic to bacteria, for instance, but it can also cause stickiness in the airway and also cause airway obstruction. There's also an increase in steroid resistance with the activation in the NLRP3 inflammasome system, an increase in asthma symptoms, and a decrease in lung function. So this is what we would call non-type 2 disease because it's neutrophilic in nature. And again, I'll define that just in a minute. So what is the relationship that we're seeing between obesity and asthma, and why is it stronger with insulin resistance? Well, there are several different possibilities. One is that the inflammation that drives asthma may also be partly driven by systemic metabolic abnormalities. And I showed you that earlier with IL-6 perhaps. Also, there may be shared immunologic mechanisms that underlie the different disease processes. So for instance, the inflammation that occurs in asthma, if it's non-type 2 asthma, if there's systemic inflammation from metabolic dysfunction, that could actually have a synergistic effect. And then possibly the drugs that are aimed to be treating insulin resistance may be a benefit to control coexisting asthma. And that's really what we've been very interested in, again, for the last 7 years. So now what I'd like to do for the next 5 minutes or so is just to briefly review the immunology that occurs in asthma. So especially in the innate allergic inflammation system. So this actually, we didn't know anything about this until about 10 or 12 years ago with the discovery of the ILC2. So ILC2s are group 2 innate lymphoid cells. They're thought of as T cells without rearranged antigen receptors. So ILC2s are not activated by antigen, but they're activated by cytokines that are produced by the epithelium. And so why is that important from an evolutionary standpoint? Well, if we're exposed to helminths, for instance, and that's probably the survival advantage of having allergic airway inflammation, those helminths come into contact with the airway epithelium. They cause the airway epithelium to release cytokines in the very early innate immune response that are going to activate the ILC2. So if you look at the adaptive immune response, it takes about a week to 10 days to get going, right? You have to take up the antigen, the dendritic cell does, has to travel to the regional lymph node, has to present the antigen to the T cell has to undergo clonal expansion, then go out to the periphery. That takes a long time. But this system is almost immediate. You can have a response to a protease-containing antigen like a helmet within just a few hours. So this is thought now also to be an amplifying effect on the adaptive allergic immune response. So in this response, what we have is, and I'm just going to briefly walk you through this. This is my rendition of Alternaria alternata. That is a ubiquitous fungal antigen that's present in the environment here in St. Louis. I know that for a fact. And what happens is when you breathe in Alternaria, and you may not even necessarily have IgE-mediated allergic inflammation, what happens is that Alternaria comes into contact with the airway epithelium, it binds to protease receptors on the airway epithelium, and it causes the release of cytokines from the airway epithelium that are going to activate the ILC2. So here we see Alternaria coming in contact with the airway epithelial cells. Another protease antigen, which is also very important here in St. Louis, are the dust mite. And it's actually not the dust mite itself that activates the airway epithelium. It's actually the protein around the fecal particle of the dust mite. That comes into contact with the airway epithelial cells, and what happens is you have the release of three major cytokines. One is IL-33. This is really important. IL-33 has been shown in multiple GWAS studies to be associated with childhood asthma, not only IL-33 itself, but also its receptor, ST2. So IL-33 is really upstream of the entire allergic response. So IL-33 activates the ILC2s. Not only IL-33, but also TSLP, thymic stromal lymphopoietin, is released by the airway epithelial cells in relationship to these protease-containing antigens, and also IL-25 as well. Now, these are somewhat tissue-specific. IL-33 is much more important in the lung, TSLP in the skin, and IL-25 in the gut. But they're all released by epithelial cells in response to pathogens. And so what happens is when these cytokines are released, they activate their receptors on the ILC2s to cause an increase in the production of type 2 cytokines, one of which is IL-5. IL-5 is really important because IL-5 is the strongest eosinophil growth, differentiation, and survival factor. And we know that eosinophils and IL-5 are important because of the fact that we have three drugs. We have mepolizumab, benralizumab, and reslizumab that target that pathway, which have been very effective in treating asthma. So IL-5 has definitely been shown in intervention studies to have an effect in asthma. Not only do ILCs produce IL-5, but they also produce a lot of IL-13. IL-13 is also a critical cytokine in asthma pathogenesis. IL-13 is a central mediator of smooth muscle hypertrophy and contraction, and IL-13 also induces airway epithelial transition, the goblet cell, to produce mucus. So these two cytokines are made by ILC2s, but in 10-fold greater quantities than what you see from CD4 Th2 cells. Now, I told you that ILC2s make IL-5 and 13. There are two other different types of ILCs. There's ILC1, which make interferon gamma. Those are analogous to CD4 Th1 cells, and also ILC3 cells, which make IL-17A and IL-22. ILC3s are analogous to CD4 Th17 cells. And IL-17 is really important because it is involved in neutrophil recruitment. It isn't actively chemotactic for neutrophils, but what it does is IL-17 released by the ILC3s or the Th17 cells acts on the airway epithelium to release cytokines like IL-8, for instance, which then recruit neutrophils. So these are really important, and the question is, okay, in obesity and asthma, it's probably not just the ILC2s or the CD4 Th2 cells, it's probably their contributions of these others. And ILC3s, again, are important in neutrophil chemotaxis, as is the NLRP3 inflammasome that I showed you earlier. So what we did was we were very interested in looking at glucagon-like peptide-1 receptor agonists. And the reason we got involved in this is very interesting. Peggy mentioned that I coached my daughter's, all our kids' basketball teams, and one of the fathers on the team is an endocrinologist at Vanderbilt. And one day after practice, literally, he said, "You really should look at GLP-1 receptor agonists in your asthma system." And I said, "Well, why would I do that? I don't even know what they are." And he said, well, these are drugs that are now coming into use for diabetes. This was, again, 7 years ago. And they have very potent anti-inflammatory effects in mouse models of an autoimmunity. I said, okay. So I usually, anybody who comes with a reasonable idea, we'll test it out in our lab, and it's led to a lot of grant funding, fortunately. Sometimes it doesn't work, but most of the times I've been lucky and it has. So we decided to look at GLP-1 receptor signaling in our allergic airway model. So these drugs are approved in Europe and FDA, and also by the FDA here in the US for treatment of non-insulin dependent diabetes mellitus. There are several different commercially available forms. Liraglutide, RLR studies that I'm going to show you in mice, we're using liraglutide. There's also exenatide, lixenatide, abiglutide, dulaglutide, and also semaglutide. And the semaglutide is important because that's what we're using in our clinical trial at Vanderbilt. So GLP-1 is made actually endogenously. When we eat a meal that contains fats or carbohydrates or proteins, it's made by the enteroendocrine glands of the small and large intestine, and it acts on the pancreas, and it acts on the pancreas to increase insulin production. That's why it's so useful in type 2 diabetes, but not type 1 diabetes. It also increases not only the biosynthesis, but the secretion, and it also downregulates glucagon secretion. It also affects the brain, and that's why it's used in weight loss, because it decreases food intake by activating satiety centers. And as I mentioned before, it also has anti-inflammatory effects in autoimmunity models. The receptor it binds to is a 7-protein G-protein couple receptor. Is present on the pancreas to increase insulin biosynthesis, as I mentioned. It's also present in the brain, as I mentioned. But very interestingly, it's very cardioprotective. So, for instance, it's now FDA approved for cardioprotective effects in people who have obesity and diabetes to prevent ischemic heart disease, which is very interesting. It also has effects on the liver, and for whatever reason, we're not even sure, but it's highly expressed in lung tissue, especially in the endothelial cells and the epithelial cells. So when GLP-1 binds to its receptor, it activates GS, which causes activation of adenylate cyclase to lead to increase in cyclic AMP and signaling through the PKA pathway. Not only does it activate the cyclic AMP pathway, but also increases ERK activation as well. So what we wanted to do was we wanted to see whether the GLP-1 receptor agonist treatment would have a positive effect in our animal model. And so the beauty of these drugs are that, as opposed to insulin, for instance, which can cause hypoglycemia in given too much, these do not cause hypoglycemia in people who are normoglycemic, or even those that don't have diabetes. So they're very safe in that regard. You don't have to worry about hypoglycemia. So the studies I'm going to show you now for the next 5 or 6 minutes or so were those performed by Shinji Toki, who's in my lab, who has an infinite capacity for work. He works harder than anybody I know, and all of the data I'm going to show you is all of his. So we entered these studies with the hypothesis that GLP-1 receptor signaling inhibits the innate pulmonary allergic response that I showed you earlier to in vivo allergen challenge using Alternaria alternata. So what we did is we take the skin testing extract that all of us as allergists use to do skin testing, and also when we put it in our allergy shots, and it contains the protease-containing antigens. So we're not actually infecting the mice with Alternaria, we're actually challenging them the antigens to which people have allergic reactions. And what we've done before is a group at the Mayo Clinic has shown that it's associated with severe asthma exacerbations. And our group has previously published that given a model where we exposed mice to 4 days of consecutive days of Alternaria, it activates the ILC2s, but it doesn't have long enough to activate the CD4 T cell response. And this causes robust IL-5 and 13 production, and also causes the eosinophilia and airway responsiveness that I talked about earlier. So in this protocol, we challenged the mice for 4 days with Alternaria, and then what we did was we harvested on the 4th day, on the 5th day, which is day 4. We treated the mice with the GLP-1 receptor agonist, exactly the same dose that we give to people. We started out at 0.05 milligrams per kilogram, and then reached the optimal human dose at 0.2 on the 4th day of the allergen challenge protocol, and then we harvested 24 hours after the last challenge. So the first thing we did after our challenges, we measured IL-5. Again, IL-5 is the most important eosinophil growth, differentiation, and survival factor. With PBS challenge, you see no IL-5 in the lungs. It's significantly increased with Alternaria challenge in the vehicle-treated mice, but the GLP-1 receptor agonist treatment decreased this by about 50%. Not only IL-5, but IL-13 the same way. PBS challenge caused no IL-13 production in the lung. There was a significant increase with alternaria challenge in the vehicle-treated mice, but the GLP-1 receptor agonist decreased by 60%. And these are lean BALB/c mice. We looked at the number of total ILC2s because we thought the ILC2s were the predominant producers of the IL-5 and 13. There was a significant increase in the total ILC2s with alternaria challenge in the vehicle-treated mice. This was significantly reduced with the GLP-1 receptor agonist treatment. We looked at the number of IL-5 expressing ILC2s. Again, this was reduced by 50% with the GLP-1 receptor agonist treatment, and again, reduced by 50% when we looked at the number of IL-13 expressing ILC2s. We looked at the histopathology with PBS challenge, and these are stains looking at eosinophils using an anti-major basic protein stain. When we looked at the PBS challenge mice treated with either vehicle or GLP-1, we saw no eosinophils, not surprisingly. But with alternaria challenge, we saw a marked increase in eosinophilia that was reduced with the GLP-1 receptor agonist treatment. And this is shown graphically here. We saw about a 50% reduction in the eosinophils with the GLP-1 receptor agonist treatment. We also looked in the BAL. Here we see the total cells in the alternaria challenge mice. It was significantly reduced in the hatched bars here with the GLP-1 receptor agonist treatment. And I want to draw your attention to the eosinophils. Again, this was reduced with the GLP-1 receptor agonist treatment. So here you have a diabetes drug. Who would have guessed? It's having marked effects on allergic airway inflammation. We also looked at airway responsiveness. We looked at a methacholine challenge. On the y-axis, we see airway resistance in centimeters of water per milliliter per second. On the x-axis, we see the response to methacholine. We use this methacholine challenge in the clinic to determine whether somebody has asthma or not, because it's a bronchoconstrictor. Those people who have asthma have a greater degree of bronchoconstriction to those people that don't. When we looked at those mice that were treated with, that were challenged with alternaria and treated with the vehicle in the red, we saw a marked increase in airway responsiveness, which was significantly reduced in the blue lines with the GLP-1 receptor agonist treatment. So this shows you very clearly that a diabetes drug has marked effects not only on inflammation, but also the physiology of asthma. Well, how is this happening? Well, we spent about 2 years trying to see whether there was a direct effect of GLP-1 receptor agonists on ILC2s or T cells, and we did not have any success because we could not find that these cells actually did express the receptor. So then we looked at, okay, what's upstream of ILC2 activation? Well, it's IL-33. So we looked at IL-33, the effect of GLP-1 receptor treatment on IL-33. This is a flow cytometry using an IL-33 reporter mouse. And so we look at the MFI, the mean fluorescence intensity. That tells us the expression of the IL-33 within the individual epithelial cell. With PBS challenge, there was very low level of IL-33, but it is present even because it's present in all the nucleus of the epithelial cells. It's significantly increased with alternaria challenge in the vehicle-treated mice, and it's decreased on a per-cell basis with the GLP-1 receptor agonist. We also looked at IL-33 release in the BAL fluid. Again, a significant increase in IL-33 in the BAL fluid and a significant decrease with the GLP-1 receptor agonist. So this was actually the first drug that was ever shown to have an effect on IL-33 release in an allergen challenge model. Again, a diabetes drug. So then we looked, we were very interested, and those all studies were done in lean mice. We wanted to look in an obese mouse model, so we looked to the tally-ho mice. This is a polygenic model of obesity where you don't have to feed them with a special diet. They get fat on their own. And we compared them to Swiss mice, which are their genetic controls. We saw that there was an increase in body weight in the tally-ho mice, suggesting this is a good model of obesity. We did a glucose tolerance test in which we give glucose to the mice at time 0, and then we measure their response to the glucose challenge by looking at blood glucose and their ability to make insulin and their responsiveness. And so what we found was there was a significant increase in the blood glucose of the tally-ho mice, which was not there with the Swiss mice, and there was increased insulin resistance. We also looked at serum leptin, and so leptin is made by adipocytes and also some mononuclear cells, and what leptin does is it's been shown to have an effect on increasing Th17 type inflammation or neutrophilic inflammation. And so there's a significant increase in the leptin levels here, and leptin's also reversely or negatively associated with FEV1. So your higher your leptin levels, the lower your FEV1 is. So we thought this was a really good model to study obesity. So we looked at IL-33 again. So these are the Swiss mice. These are the lean controls. These are the tally-ho mice here. These are the alternaria challenged mice treated with either vehicle or the GLP-1 receptor agonist. And we looked at IL-33 in the BAL fluid. In our lean mice, we saw an increase in IL-33, significantly decreased with the GLP-1 receptor agonist treatment, as I showed you before, and about the same level of IL-33 in these mice. But what has surprised us was we looked at TSLP, and in our obese mice, there was a significant increase in TSLP expression, which was not present in the lean mice. So it seems to be, and nobody's proven this in humans yet, that obese animals, at least, have an increase in another inflammatory mediator that's involved in activating ILC2s. And this was significantly reduced with GLP-1 receptor agonist treatment. We looked at the lung ILC2s, and again, there were more lung ILC2s in the tally-ho mice, the obese mice, compared to the lean mice, and it was significantly reduced with the GLP-1 receptor agonist treatment. We looked at lung IL-5. It was significantly more increased in the obese mice compared to the lean mice, although in both groups there was a reduction in IL-5 with the treatment. The same thing was true with lung IL-13, and interestingly, because this is a model of obesity, we were very interested to find that in our obese mice, there was a significant increase in neutrophils compared to the Swiss mice. So this, again, parallels what we see in people. And surprisingly to us, actually, that what we found was there was a reduction in the airway neutrophils with our GLP-1 receptor agonist treatment, suggesting maybe there's an effect on the inflammasome, downregulating inflammasome activation, or maybe there's a downregulation in IL-17. And again, there was a reduction in the airway eosinophils. I use the same scale here as with the neutrophils to show you that this is, in the obese mice, this is really a model of allergen-induced neutrophilia. We also looked at chemokines that are involved in neutrophil recruitment. They were significantly reduced in the tally-ho mice with GLP-1 receptor agonist treatment, and also CXCL5, another neutrophil chemotactic, the same thing. So what we were very interested in then is we looked with, we didn't do it, actually Katie Cahill did it, and this is Katie here. We recruited her from Brigham and Women's Hospital, and they had a published paper that was published actually in the Blue Journal now about 3 years ago, looking at asthma exacerbations in type 2 diabetics with asthma on GLP-1 receptor agonist treatment. So basically what they did was they took the Harvard Health Plan system, and then what they did was they looked at people who had diabetes who were going to be started on new drugs for their diabetes. And these were all people who had asthma. So they looked at the people who had GLP-1 receptor agonists as their new drug, or the DPP-4 agonist, or insulin. And what they wanted to do was what was the time to the first exacerbation and the number of exacerbations after they were started on those new drugs. So these were people who had type 2 diabetes and asthma, and again, they were started on a GLP-1 receptor agonist, insulin, SGL2 inhibitor, or a DPP-4 inhibitor, or sulfonylurea. And so what they did was they looked actually at the type 2 diabetes drug class, and they looked at the incidence ratio of asthma exacerbations. And here, the GLP-1 receptor agonists are given an odds ratio of 1, and all of the other drugs had an increase in the asthma exacerbations compared to the GLP-1 receptor agonists, suggesting that GLP-1 receptor agonists also downregulate asthma. So this led to our GATA-3 study that Katie is now the PI of. GATA-3 is actually the master transcription factor for the Th2 development, and Katie did some really heroic gymnastics here to get this to fit, the title of this, but it does. And so it's a 24-week randomized controlled trial in 100 adults at Vanderbilt, and we're using semaglutide here, which is a once-a-week GLP-1 receptor agonist. At 2.4 milligrams, this is a treatment for diabetes or a matched placebo. And we're looking at asthma clinical outcomes, asthma quality of life scores as the primary endpoint, and also looking at inflammation as measured by sputum eosinophils, blood eosinophils, and actually we're doing adipose biopsies on these people looking at the ILC2s with the GLP-1 receptor agonist treatment. So the patients come in at 4 weeks prior to study for screening. There's a run-in phase, they're randomized, and then every 4 weeks, we start them off at 0.24 milligrams, and every 4 weeks we increase the dose by about twofold, and this is the normal standard way that you would treat people with semaglutide. And we look at them at week 4, week 12, and week 24. And we picked, actually, our primary inflammatory endpoint is week 12 because we wanted to get them before they lost significant weight. We wanted to find out what the effect was on inflammation independent of weight loss. And so this study, we had our first subject visit about a year ago now. We estimate that our last subject will be enrolled in November of 2025, 2 years from now, and we're right on target for this, which is a real tribute to Katie, and our estimated primary outcome we'll have in May of 2026. So this is our team. This is Gordon Bernard, who is the co-I with Katie Cahill. And this is Kevin Nicewinder, my friend, who's a basketball coach who taught me into doing the initial studies in the mice. This is Pingxing Wu, who is our biostatistician. So with that, I really appreciate the opportunity to be here today. Thank you. You've been a very attentive audience, and I'm happy to take any questions if we have time for it. Yes, ma'am.
So that was a terrific talk.
Thank you.
Showed in some of the slides that there were gender-related differences, and what's your hypothesis about why that is?
That's a really good question. So the question is, what's the hypothesis about why women seem to be more affected than men? So I'm very, very fortunate to have a collaborator at Vanderbilt named Dawn Newcomb, who is actually studying gender-related questions in airway inflammation. It turns out that women make much more IL-33, or females make much more IL-33 than males do, both in mouse models and also in human airway epithelial cells. So I think probably what's happening here in the women is that there's more IL-33 genetically that's made, and therefore that's having a greater impact on the inflammation. So it's very clear that actually that female epithelial cells are different, and also the T cells and the ILC2s are different as well. The male ILC2s do not make as much IL-5 and 13 as females ILC2s. So there's a difference in the inflammatory component. That's a fantastic question. Any other questions? Yes, sir.
There is a cohort of obese patients who we've kind of alluded to it, is they don't respond to medication.
Yes.
They're always wheezing, they have airways obstruction, and they're not reversible on pulmonary function testing.
Yes.
And when you do imaging, not only do you find evidence of small airway disease, but you see a lot of dynamic collapse of the larger airways.
Yes.
Do you think those patients really have asthma? And if not, how do you differentiate between the true asthmatics and those patients?
So the question is, how do you differentiate people who have obesity and large airway collapse compared to people who may not be obese? And you know, that's another hour-and-a-half lecture in itself. So I think that asthma is predominantly a clinical diagnosis with some testing that goes along with it, like methacholine challenges and pulmonary function testing. I think part of it is it asthma? Not all asthmatics respond to bronchodilators, but if they do, that's highly suggestive that they have reactive airway disease and potentially asthma. If you have patients like that, please send them 5 hours to Nashville, and we will put them in our study. We're happy to look at them. Yeah. And again, I have to say that this is off-label, right? This is a clinical trial. This is not FDA-approved, the GLP-1 receptor agonist treatment, but hopefully in about 5 years it will be. Yes, sir.
That was a great talk.
Thank you.
There's a lot of work that's been done with GLP-1 agonists and antagonists in clinical studies. Are there any signals that is targeting obese populations that you wonder if there's a little overlap of airway reactivity or asthma?
We've looked and we can't find it. So, mainly because in the GLP, when they're looking at the diabetics, they're not asking questions about asthma, I believe. They're more interested in, upset stomach or weight gain or whatever else. But we've not been able to find a study where we've actually found, where they actually have looked as asthmatics specifically and whether their asthma got better. But that would, that would have been a terrific thing on the front end if we had known, 10 or 15 years ago that this possibly could be the case. It would have been great to have looked at that, but there's no data. Actually, the only clinical data that we have actually is the study I showed you from Katie looking at the Harvard healthcare system showing that, that if they're on a GLP-1 receptor agonist, they had a decrease in their asthma exacerbation rate compared to the other diabetes drug. But that's a great question. Looks like we've got one more minute. If anybody has a pressing question, or you guys can go to clinic. Yes, ma'am.
So, I don't know much about that. I'm an endocrinologist. So it appears that pulmonologists are doing what we're doing, which is moving from therapies that add weight to patients, steroids in your case, to therapies that are either weight neutral or potentially are able to reduce weight. So the question is, are you using steroid exposure even as or steroid requirement, steroid exposure as exacerbations in the clinical trial it's really problematic to put overweight patients on steroids.
Absolutely.
The reason you don't
yeah.
see a whole lot in clinical trials is steroid-taking patients are often excluded, and we don't really like even intermittent steroid use because it sort of makes a mess of their glucose control.
Very, very important question. So in our study, what we're doing is we're adding this on to current therapy, whatever therapy they're on. We're not adjusting their therapy. That keeps us out of trouble with the pulmonologists in Nashville because they don't want us doing anything to their ordinary asthma medications other than putting them on this drug. But the point you made is really, really important. And the reason so is because, for decades, all we had for treat allergic inflammation, all severe asthmatics looked the same. They were all Cushingoid, right? And by putting them on steroids, because we had nothing else, right? With the new biologics, with omalizumab targeting IgE, the IL-5 antagonist, dupilumab targeting the IL-4 receptor, now we have things that we can prevent the patients from having to go on steroids. But you wonder how much damage we were doing in those, in the 70s, 80s, and 90s before the biologics came along by, having people on 30, 40, 50 milligrams of prednisone to control their asthma. They were getting obese, and that we were changing their inflammation composition, but maybe to their detriment. But again, at that particular time, we had no choice. But I think you're right. We absolutely want to get people off steroids because of the fact that they cause metabolic derangements, as you mentioned, glucose control. The fact that there's weight gain, we know now that that's not a good thing. And so now being able to target, this is what's so exciting about being an allergist now, is we have drugs. We can act like rheumatologists and actually intervene on the immunologic pathways, right? So, but I think your question is a fantastic question, right? Great. Thank you all for coming. Is that okay? Vicki, thank you.